A great morning to everyone. Today I will be discussing dissociative disorders. The salient feature of dissociative disorders is dissociation, which is normal because it is actually our mind's innate capacity to engage in complex mental activity independent of conscious awareness. It is not in itself pathological because we all dissociate at a certain point in time. In fact, when we daydream or when we drive miles way beyond our destination without realizing how we get there, we exhibit mild dissociative symptoms. It only becomes pathological when these dissociative symptoms are perceived as disruptive and recurrent. The disruption causes a significant loss of needed information and produces discontinuity of experience. Recurrent episodes lead to involuntary intrusions in executive functioning and jarring the sense of self. The disorders classified under this group are characterized by either or both disruption and discontinuity in the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. The dissociative symptoms experienced can potentially disrupt every area of psychological functioning. It includes dissociative identity disorder, dissociative amnesia, depersonalization derealization disorder, other specified dissociative disorder, and unspecified dissociative disorder. We first go to the least severe among the three disorders, depersonalization derealization disorder, that is. It occurs following the disruption of body self-awareness. Either depersonalization or derealization may happen, or a combination of both episodes. Depersonalization is characterized by some sort of a feeling of detachment from one's whole self or aspects of the self, as may be expressed in the phrases, "I have no self," or "I feel though as I'm not alive." There may be detachment from affect or from what patients feel, thoughts, whole body parts, or sensations. Others also claim that they feel like they are a robot or their actions or speech are automated. Disconnection from memories may also happen, where patients may have trouble remembering them. Out-of-body experience may also be observed. Derealization, on the other hand, is a feeling of detachment from the surroundings, example, people, objects, or everything, which seem unreal. Patients may feel as if they are in a foggy dream or as if a glass wall or veil separates them from their surroundings. Common to this is the experience of subjective visual and auditory distortions of the world, as may be manifested by the following examples. Objects may appear blurry or unusually clear. They may also seem flat or smaller or even larger than they actually are. Sounds may also seem louder or softer than they are, or time may seem to be going too slow or too fast. These symptoms are almost always distressing, and when in their severe form, can be profoundly excruciating. Patients may also experience anxiety and depression. There are those who fear that they have irreversible brain damage or that they are actually going crazy. Some may also obsess whether or not they really exist and may repeatedly check to determine whether their perceptions are real. However, patients always retain the knowledge that their unreal experiences are not real, but rather are just the way that they feel. This awareness differentiates depersonalization derealization disorder from a psychotic disorder, in which such insight is always lacking. Of course, the disturbance is not better explained by the physiological effects of a substance, such as a drug, medication, or another medical condition, seizure in particular as an example. Moreover, the disturbance is not better explained by another mental disorder, such as schizophrenia, panic disorder, major depressive disorder, acute stress disorder, post-traumatic stress disorder, or another dissociative disorder. Those who have harm-avoidant temperament, immature defenses, cognitive disconnection schemata, and overconnection schemata are put at a higher risk towards developing the disorder. Those who had childhood and personal traumas such as extreme emotional abuse and neglect, physical and sexual abuse, being a witness of domestic violence, or those who grew up with a seriously impaired parent may also have greater risks. Moreover, severe stress and illicit drug use may also heighten one's vulnerability towards developing the disorder. Symptoms may be induced by substances such as tetrahydrocannabinol, hallucinogens, ketamine, MMDA, and salvia. Marijuana use may, on the other hand, precipitate new-onset panic attacks, and depersonalization-derealization symptoms simultaneously. Patients with depersonalization-derealization disorder may improve without any intervention. Complete recovery is possible for many patients, especially if symptoms result from treatable or transient stresses. In others, depersonalization-derealization become more chronic and refractory. Even persistent or recurrent depersonalization or derealization symptoms may cause only minimal impairment. That is, if patients can distract themselves from their subjective sense of self by keeping their mind busy and focusing on other thoughts or activities. But for some patients who may need intervention, such as in cases where patients may not able to distract themselves from their subjective sense of self, there may be a need for psychotherapy and or medication. In psychotherapy, the treatment is focused at reducing stresses associated with the disorder. Several techniques can be employed such as cognitive, behavioral, and grounding. Psychodynamic therapy as well as moment-to-moment tracking may also work for some patients. Let's take a look at the case of M. In the case, she has reported complaints did not feel her body, as if her body is hollow and it's not her own. Now, this is a clear indication of the presence of depersonalization. She suffered from affective detachment and developed intense anxiety in social situations. She also had slightly depressed mood and panic-like symptoms. There were no history of drug abuse and no abnormalities evidenced by normal results in EEG and neurological exam. These symptoms and their consequences in the social aspect of M, along with the evidence that during such episodes, reality testing remains intact, are suggestive of depersonalization-derealization disorder. Treatment focused on medication. It first started with risperidone and eventually to SSRI because she was unresponsive to the former drug. Though SSRI reduced her anxiety levels, specific symptoms of DPD became worse. The third drug, venlafaxine, led to a significant mood improvement and reduction in panic-like episodes. However, depersonalization and derealization remain unchanged. Lamotrigine was then added to her medication. She showed improvement in affect, interpersonal contact, and in social interaction. The symptoms of depersonalization gradually decreased, allowing her to go back to work. The improvement was also validated through the Cambridge Depersonalization Scale, with an original score of 230 to 198 and 175 respectively. For the second case, it is evident that Bonnie has had episodes of depersonalization. She complained that she is flipping out, which means that she feels that she is not herself when she is on her modern dance class. Apparently, she can't also feel her legs, and there are times when she feels like she is standing at the back of herself watching. There may also be derealization as suggested by her statement that she gets totally separated from what's going on around her and that she experiences tunnel vision. Bonnie's problems were induced by smoking marijuana about 10 years ago. The feelings that she felt in her dance class was the same when she smoked marijuana for the first time. There were no mentioned treatments for this case, and it is assumed that Bonnie may have been able to manage the disorder. The second disorder is dissociative amnesia, which is found somewhere along the middle of the continuum. This disorder is different from the amnesia that we usually know because it does not involve brain pathology. From previous knowledge, we recall that there are two main types of amnesia, retrograde and anterograde. Retrograde is a partial or total inability to recall or identify previously acquired information, whereas anterograde amnesia is a partial or total inability to retain new information. Now, if brain pathology is involved, the usual resulting consequence is anterograde amnesia. This is why dissociative amnesia is mostly associated with retrograde amnesia. Dissociative amnesia by DSM-5's language is a failure to recall previously stored personal information, and that failure cannot be accounted for by ordinary forgetting. It appears that it may be caused by traumatic or stressful experiences endured or witnessed, or by a tremendous internal conflict. The DSM-5 mentions 5 types of dissociative amnesia: localized, selective, generalized, systematized and continuous. In localized amnesia, there is a failure to recall events during a circumscribed period of time, and it's the most common form of dissociative amnesia. It may be broader than amnesia for a single traumatic event. Sometimes it may be months or years surrounding the traumatic event. Selective amnesia is not as broad as localized because an individual can recall some parts during the circumscribed period of time. An individual may recall some parts of a traumatic event, but not the other parts. In generalized amnesia, there is a complete loss of memory of one's life. Individuals with this type may forget personal identity and may also result to losing previous knowledge about the world as well as inability to access well-learned skills. This is a rare form of dissociative amnesia, and the onset is acute. There is perplexity, purposeless wandering or travel, and disorientation. As such, it is more common among combat veterans, sexual assault victims, or those who experienced a great deal of stress. In systematized amnesia, the individual loses memory for a specific category of information, such as all memories relating to one's family or childhood sexual abuse. In continuous amnesia, an individual forgets each new event as it occurs. The specifier with dissociative fugue may also be associated with generalized amnesia, as it is characterized by travel, bewildered wandering, and disorientation. The French word fugue translates to flight. Thus, dissociative amnesia may etymologically mean defense by actual flight. Dissociative amnesia with dissociative fugue renders an individual confused about who he or she is, and they can also lose deeply ingrained skills. A fugue may last from hours to months, or occasionally longer. If the fugue is brief, they may appear simply to have missed some work or come home late. If the fugue lasts several days or longer, they may travel far from home, assume a new name and identity, and begin a new job, unaware of any change in their life. Sometimes memories may return quickly, as can happen with patients are taken out of the traumatic or stressful situation. In other cases, amnesia, particularly in patients with dissociative fugue, persists for a long time. The capacity for dissociation may also decrease with age. Most patients recover their missing memories, thus resolving the amnesia. The prognosis is determined mainly by the following: the patient's life circumstances, particularly stresses and conflicts associated with amnesia, and the patient's overall mental adjustment. As for the treatment, patients can undergo memory retrieval where hypnosis or drug-induced semi-hypnotic state is instituted. Psychotherapy is also used to deal with issues associated with recovered memories of traumatic or stressful events. Once the amnesia is lifted, treatment helps with giving meaning to the underlying trauma or conflict, resolving problems associated with the amnestic episode, or enabling patients to move on with their life. Psychotherapy, sometimes combined with hypnosis or drug-facilitated interviews, may be used to try to restore memory for patients who experience dissociative fugue. Let's examine the case provided. Mr. A showed symptoms of dissociative amnesia in two settings. At work, he wasn't able to recognize his friends and was asking what he is supposed to do. At home, he failed to recognize his mother, dog, siblings, and belongings. Moreover, he was unable to recall how or why he came to the parking lot of a convenience store. There is also a loss of personal information, as evidenced by the inability to provide important details pertaining to his life. He manifested a seemingly flat affect and no concern for his memory loss or labile indifference. Though he has a strong orientation in time, place, and person, he showed impaired attention and concentration. Apparently, these symptoms were observable after a recent breakup with his partner, with which it was because of his unfaithfulness. There was no organic cause found, as evidenced by a negative result in his urine for any illicit substances, normal results of head computed tomography and MRI, and normal limits of blood count, metabolic profile, and other tests conducted. Malingering was also ruled out. The results of the Miller Forensic Assessment of Symptoms and Coin-in-Hand test showed no evidence of feigned symptoms. The Personality Assessment Inventory showed no evidence of over-reporting. The patient was diagnosed with dissociative amnesia with dissociative fugue. Psychotherapy was used as a treatment. Persuasion and suggestive techniques, as well as supervision of a sense of safety and security, was first instituted. He was also given a home assignment to look at his family photo album and review details of his job with his co-worker. Simultaneously, the psychotherapy team continued supportive psychotherapy and empathic validation. Initially, Mr. A felt good about being a brand new person so that he did not have to think about the painful aspect of the past. After a series of sessions over a period of 12 to 16 weeks, Mr. A continued to show progress by returning to his job and started remembering details from his past. The third disorder in this group is Dissociative Identity Disorder. This is to debunk the misleading connotations regarding this disorder that those diagnosed have multiple, fully organized, and coherent personalities that are capable of occupying space, time, and people's bodies as suggested by the term multiple personality. The ID's characteristic feature is the presence of two or more distinct personality states or an experience of possession, as may be described by some cultures. The personality states may be covert or overt, depending on psychological motivation, current level of stress, culture, internal conflicts and dynamics, and emotional resilience. Overtness of these personality states are mostly evident in individuals with possession form cases and few from non-possession form cases, whereas covertness usually happens in non-possession form cases of the disorder. In non-possession form cases where personality states are not directly observable, the disorder can be identified by two clusters of symptoms. One is sudden alterations or discontinuities in sense of self and sense of agency, and two is recurrent dissociative amnesia. In the first cluster, individuals may report a feeling of becoming an observer of themselves, speech and actions. They may also report perceptions of voices, child's voice or the voice of a spiritual being. These voices may be experienced as multiple, perplexing, independent thoughts streaming over which the individual may feel powerless to stop. Strong emotions, impulses, and even speech or other actions may also suddenly emerge without a sense of personal ownership or control. There may also be sudden back and forth shifts in attitudes, outlooks, and personal preferences such as food, activities, and dress. Such symptoms can be witnessed by family, friends, or the clinician. Non-epileptic seizures and other conversion symptoms are prominent in some presentations, especially in some non-Western settings. In the second cluster, dissociative amnesia may manifest in three ways. 1. Gaps in remote memory of personal life events. 2. Lapses in dependable memory. Or 3. Discovery of evidence of their everyday actions and tasks that they do not recollect doing. Dissociative fugue is also common. Individuals may report that they have found themselves at the beach, at a nightclub, or possibly could be anywhere with the memory of how they came to be there. In possession form, there is an overt observance of the personality states. As such, this is what is commonly portrayed by the media, such as in the movie Split. It appears as if a spirit, a supernatural being, or an outside person has taken control. There is usually a host identity and alter identities. The host identity is the most frequently encountered and carries the real name of the person. The alter identities may assume different gender, age, handedness, handwriting, sexual orientation, predominant affect, foreign languages spoken, and general knowledge. However, these alter identities are not in meaningful sense personalities, and it reflects a failure to integrate various aspects of a person's identity, consciousness, and memory. It is most important to note that most people with DID have some identities that are completely unaware of the existence and experiences of a certain alter identity. Studies show that when one identity is asked to learn a list of word pairs, and an alter identity is later asked to recall the second word in each pair using the first word as a clue, there seems to be no transfer. Presumed causes of DID are interpersonal, physical, and sexual abuse, and other traumatizing experiences. Two theories are usually used to explain the cause of DID: post-traumatic theory and sociocognitive theory. Post-traumatic theory states that DID stems from the child's attempt to cope with an overwhelming sense of hopelessness and powerlessness as a result of repeated traumatic abuse. The sociocognitive theory, on the other hand, claims that DID develops when a highly suggestible person learns to adopt and enact the roles of multiple identities, mostly because clinicians have inadvertently suggested, legitimized, and reinforced them, and such identities are geared towards personal goals. Apparently, there is no specific treatment for DID. However, psychotherapy, hypnotherapy, and adjunctive therapy are used as in long-term treatment. For our sample case, the 55-year-old Caucasian female has a history of substance abuse and a comorbid bipolar disorder. It is reported that she experienced a fragmentation of a single personality into different personalities under emotional stress and under the influence of drugs. Clinical evaluation has shown that such personalities are a 7-year-old child, a teenager, and a male person. The 7-year-old child is moody and has a self-arrogant personality. The personality shows weeping spells if wants are not met. The teenager has sharp choices, while the male person would make the patient dress like a male, as well as there is a change in language, perception of male body parts, and attraction towards females. The patient becomes violent towards people around her when she experiences this fragmentation. She also had anxiety. Treatment included psychotherapy with cognitive behavioral therapy addressing stress and substance use disorder. Medication was also used to reduce her anxiety symptoms. The patient's condition did not differ significantly after 6 months, contrary to self-report that her stress was getting better. The patient continues to receive treatment. Finally, if these symptoms do not fully meet the criteria for each of the 3 disorders, the individual may be diagnosed with other specified dissociative disorder if the clinician opts to communicate the reason why such presentations do not meet the criteria for any specific dissociative disorder, or unspecified dissociative disorder if the clinician chooses not to specify the reason why the criteria for any specific dissociative disorder are not met. Examples of presentations for other specified dissociative disorder are chronic and recurrent syndromes of mixed dissociative symptoms, where an identity disturbance is associated with less than marked discontinuities in sense of self and agency, while alterations of identity or episodes of possession in an individual who reports no dissociative amnesia. Second is identity disturbance due to prolonged and intense coercive persuasion, where individuals have been subjected to intense coercive persuasion. Third, acute dissociative reactions to stressful events, where there is an acute transient conditions that typically last less than 1 month and sometimes only a few hours or days. The last one is dissociative trance, where there is an acute narrowing or complete loss of awareness of immediate surroundings that manifests as a profound unresponsiveness or insensitivity to environmental stimuli. As a summary, we can say that dissociative disorders are found along a spectrum of severity. Depersonalization Derealization Disorder is the least severe, dissociative amnesia is somewhere in the middle, and dissociative identity disorder is the most severe. Individuals with dissociative identity disorder may present symptoms of depersonalization or derealization, such as feelings of detachment from the self or surroundings, and dissociative amnesia, which is a failure to recall mostly personal information that is not accounted for by ordinary forgetting, along with 2 or more distinct personality states that could manifest as either possession form, which is mostly overt, and non-possession form, which is largely covert. And, as what can be observed from these disorders, the presumed cause is stressful or traumatic events. Some experts say that dissociation happens as a way for the self to cope with the stresses brought about by the surrounding environment. That's it for today. Thank you for tuning in. Bye-bye.